What I'll be talking about are the trials, and we've heard about these, and we've been bathed in these, but I'm a big believer in tell them again, and tell them again, so we really get it. I'll give you a little bit of a different perspective. So I've kind of phrased this as where have we been and where are we going in terms of these trials. Well, when I started doing this, besides burning trees, I put all the studies together and I realized I had 4 inches worth of data that I'm going to have to go over in 7 minutes. So rather than doing the movie, which people accuse me of doing these kind of slides very quickly, I'm not going to do that. I want to go through some themes. I think it all started from a coronary cardiovascular point of view with the whole issue of opening blood vessels and getting rid of clots. So we started with the open artery concept, and then we moved on to the quality of doing that, the quality of flow, and the importance of speed involved, so the issue of time. Those were a couple of decades. Then we got into this whole issue of open artery versus open muscle, the sort of Mike Gibson business, and Timmy 30, and we still have room for improvement in that space. We've kind of blown past that, and we've kind of put that in the pharmacologic world, but there's a lot of opportunity still to improve that. And then we had insight from these early trials, and we heard about this yesterday, the sort of sub-study that Tim Sanborn wrote, if you added a mechanical support device, some means of pumping to this, you suddenly saw some improvement of mortality, but we hit a floor or a ceiling, whatever you want to call it, where we haven't budged from that point. And in fact, even though you're going to see with these studies, and you heard already that balloon pumps are here and there, there was a call early on that we were underutilizing them in acute MI in the early studies. My, isn't that interesting? It's where we are. So this could not only improve coronary flow, but it could afterload reduction and reduce myocardial oxygen demand. And then we went through this whole series of small studies which showed really no improvement in efficacy, yet safety was actually worse. So that kind of set us a little bit back. Then, of course, you've seen it several times in the meeting so far, IABP shock. The point is timing. Within 30 minutes up to 12 hours. I mean, so many things are going on in that period, so you're dealing with apples and oranges and a melange of different things going on. And this study looked very nicely at events at 30 days, at a year, and at 6 years. And as we saw, there was no survival benefit at 30 days, and still no survival benefit out at 6 years. So what are the issues that came up? I mean, there are many. From a trial design point of view, it's non-blinded, open-label study, the whole business about catecholamine use and what it's doing, the timing of the insertion of the support pre and post. These are all critical things. And then, is this a pump? It's a minimal pump, 30 to 40 cc's, inflated a few times with half the flow going backwards and forwards. It's not a major pump when you deal with things like, remember, I'm the artificial heart guy. That's a pump. Then we have the issue of coronary reperfusion, RV issues, LV unloading, open artery and muscle, and of course the downgrading, which creates a mentality about what we do with this. Of course, the work of Bart Mines and others with the Impella, and that got us going. But these studies for years were very hard to enroll. We had the IMPRESS trial. It still was short of its goal and basically showed no big improvement in mortality. And as Bill O'Neill's going to talk about, I told him outside I'm the lead-in for his work, there are nuances here as far as the speed of implantation. If you put this in quickly, in the first hour, you had an impact in terms of survival, in terms of in-hospital mortality. And he's going to go through the 15,000 patients in the quality registry, which basically showed that if you put this in before PCI, if you dealt with younger patients, we heard about age this morning, and if you had a volume of operator experience, as well as monitoring hemodynamics, you actually could have some impact in terms of mortality. But I want to shift to a different paradigm. This really came with Navin Kapoor and others, where basically the idea of unloading. We haven't really gotten into this. And this was in a porcine model, and this showed that if you had 30 minutes of unloading, that this actually had an impact as far as outcomes. And what this opened our mind to is that there were a lot of biochemical and molecular and genetic things going on. Different genes were turned on. There was a transcriptional event. And I'll slow down here for a minute. There's a difference in outcome between 15 minutes versus 30 minutes. And I can tell you as a molecular biology guy that that implies there's a transcriptional event. These things don't happen instantaneously. Things take time. We know that there are parallels to this even in the world of chronic heart failure. You know, people give instant beta blockers versus chronic beta blockers. It takes time to have the switch in terms of beta receptors. So there is time dependency. There was a metabolic effect in terms of mitochondria seen here. There was a preservation of a anti-apoptotic factor. There was reduction of MMPs that was seen, and there was generalized reduced apoptosis by doing this type of procedure early on. Of course, when you translated it in the first study, they didn't see a change, but that doesn't mean it's out and it was safe, and it will certainly go on. We know we're doing the door-to-unload trial, which is going to move forward. And we know, and we heard yesterday about the danger shock trial, which is going to add this as well. Yet, of course, just came out in JAMA, a study which basically looks at Impella, showing again higher incidence of in-hospital death and bleeding. But again, we need to be careful because we are sort of being bamboozled by a retrospective propensity match study where it's really hard to propensity match. What does that really mean? Dan spoke about that yesterday. And to me, I'm not going to be biased by this. I still believe that there's value in the technology. And I added this concept that we're being whipsawed. You know, we're being vacillated between the two different points of view of what's really going on with these types of technologies. And then we've got the whole issue of ECMO, which we'll hear a lot more about. I'm not going to get into extensively, but the combination of good perfusion plus unloading certainly has impact and would be a smart strategy. So where are we going as far as trials? We've got several new studies coming on, and we have many studies which are going to look at the combination and ECMO, Euroshock, ECLS, Anchor, which will give us more insight into where we're going to go with that. And if all else fails, I'll remind you of a study we did a couple years ago where we basically looked at the total artificial heart to save you. That's not necessarily going to save the heart, but it's going to save the patient. And there we showed that we actually could very successfully bridge patients to transplant when we knew things were pretty much gone. So what's the way forward? I think for the here and now, you know, when I look at the JAMA paper, it's all about adverse events. You know, you may have a pretty good effect, but if you're bleeding and we have access problems and we have issues related to that, then it's going to diminish the quality of what may be going on with a minimal hint of positivity. So better access, less bleeding, less hemolysis. The fact that these short-term devices, we published a paper this past year about hemolysis as a driver of thrombosis, and you're going to get microvascular thrombotic events. So there are many things going on, less inflammation. If you look at ECMO, it's a laboratory experiment in terms of biomaterials. You've got too many things going on. Now, medicine operates at a multi-scale level. We heard hints of that today. I will tell you that cardiogenic shock operates at a multi-scale level, and we need to look beyond just the level of the patient. We need to understand the input variables. I added the concept of dx over dt, whatever's going on, the slope of illness. We need to define a lot of these other variables so we can ultimately get to precision shock therapy for the patient by understanding that this is a melange of multiple different events going on at the cellular, biochemical, and even molecular level. I realize we don't have a way to address that instantaneously, but we heard what we heard this morning, the need for separating these types of scores, separating the goal and role of this deconstructionist strategy. And we know from Einstein, if we keep doing the same old thing, that's really not insight as to where we're kind of attempting to go. So I think we really have to define what we're trying to accomplish. Is it instant therapy? Is it prognosis? Is it definition of this biochemical state that the individual has? And if we get to that point of being able to come up with those types of variables, then I think we're going to have an impact going forward. And that's not going to help us instantly solve the problem, but that's the way forward. We're dealing with big data and AI. I think if we start, we heard that we're going to have a mandate for national database to put all this type of stuff in. Those answers will come over time. They're not going to help us instantly in treating a patient in front of us, but we need to have different lenses. I always say, I teach an innovation class, you have to put different heads on. We have to put the head of the physician on right now when we have a patient in front of us, but we also have to put the head of a researcher on if we're going to attempt to move a project forward. We have to think about, are we looking at it surgically? Are we looking at it interventionally? Are we looking at it as a potential new pharmacologic therapy. I think if we look at things on multiple different levels, from a research point of view, then we'll get to a point. It's not going to happen in a year or two. This is a 5 to 10 year Manhattan project to really solve this, but eventually we'll be able to do it. Thank you very much. Questions?
Marvin, that was excellent talk. Just real quick, the unloading trial, I'm just confused. I mean, Mike and I open up the arteries, right? And we're told all these years, get the artery open up fast.
Sure.
Our mortality rate in the anterior MIs is actually pretty low. Mike can probably speak to this with some actual numbers. Now you're telling me stop, unload, wait 30 minutes, then open it up.
Let me explain. I mean, I'm not telling you exactly to do that, but I think what the preclinical study is telling us is that you've got this acute ischemic event. So granted, we have no flow, time is muscle, we understand that, and you have a decline. But that ischemic event, you know, we sort of had this idea of the golden window. The golden window is probably the golden moment, where as soon as something starts, you've now initiate a cascade of biochemical responses that are going on in the myocardium that if you don't do something to kind of get you off of that pathway, you're going to, no matter what you do as far as providing flow back, they're already started. But if you start to unload, this is the hypothesis. If you start to unload, you then allow certain responsive transcriptional events to occur which are protective. You know, the body has a myriad of protective responses that we're just beginning to understand. There's the most basic thing like heat shock proteins, chaperonins. They are mechanisms that prevent early damage to attempt to refold things. But they have to be recruited. There's some constitutive elements, and then there are inducible elements. It turns out that just in 30 minutes, you can start to see RNA expression or preservation of certain things by allowing that type of thing to happen. You're going to get flow back anyway, but let's get flow back when the myocardium, let's say, is prepared for that. And then there's the whole issue, even if you don't buy any of this stuff, there's still the whole issue of microvascular flow. I mean, I grew up, you know, I interestingly grew up with this stuff in the sense that I was in the Bellevue Sinai Reperfusion first trial. Then when I was a fellow, we were doing the SOD study, trying to open up beds. That didn't fly. But there's basis to that. We don't have a way to really know that the microvascular bed is open when you're doing that. You know, the blush score, it's only at the level of sensitivity. You're looking at the 4x objective. We need to look at the 40x objective on a microscope, you know, the analogy of what's really happening at the myocardium. We don't have ways to do this, you know.
Marv, that was
David.
very excellent, and that was very eloquent in your response. I kind of wanted to give some feedback about what I thought. Mike and I used to be partners and did a lot of this stuff over 10 years ago. And unfortunately, a theme that I've seen all today, I don't know whether it's unfortunate or not, but it's where we are in the current era, which is that we don't have a lot of facts and data. And what we've heard today is a prevailing theme is that the gestalt of clinical medicine tends to prevail right now in terms
Sure.
of what we do. So what I think an interventionalist can actually do is that, in fact, you know, when you've been doing it for as many years as you have, you know whether something's a high-risk PCI from the very beginning. If Mike thought he could get the vessel open without me being in the room, he would do that, and then if the patient was still in cardiogenic shock, then we'd put in a ECMO device. If he thought that as soon as he opened that vessel, that either from arrhythmias or the patient was unstable enough, or if they in fact were already dead, so that we already had, you know, a device on them, you know, to resuscitate them, then we would actually waste that time to actually put in some type of unloading device to start with, or an ECMO support device. If in fact you couldn't decide, we just had two people in the room, and we had two operators, one that was working on the wrist and opening the coronaries, while the other one was putting in an ECMO circuit.
Sure.
That's a
I think
kind of
shock. I think shock though is a different scenario than what the unloading trial is all about. Those are non-shock patients. That's anterior MIs. And Mike's mortality rate, I can tell you, he'll tell me his number, is extremely low in anterior MIs without shock.
Yeah,
I mean,
you know, there's complacency is not a good thing, though. You know,
Sure.
we have generated, we tend to congratulate ourselves a little bit too early. There's a fair amount of diastolic dysfunction that happens in these big anterior MIs. And any randomized trial that validly asks the question, how can we do better? Boy, we really should support that, because that's what we're all about, is trying to do better. And there are things that we can do better. If the MI on load trial works in regular anterior MIs, you know, it gives us a pathway forward to approach even higher risk patients.
You know, one of the things that had to be controlled when we go forward, you know, when I look at that, even the simplest thing like the degree of collaterals. You know, I always joke, sort of as a science guy, is that, you know, man is between a dog and a pig, and I'm not commenting on your personality, but it really makes a difference whether you're more dog-like or you're more pig-like. The point is, it's really hard to infarct a dog because they have multiple collaterals. On the other hand, a pig, you look at them wrong, they're going to die because they have no collaterals. So that's a big point. And I think that's a very important point as far as, and then you'd have even more confidence to wait another 20, 30 minutes if you knew that you had that going on, because you're sitting there, you have a pump in, things are happening biochemically. We need a way to monitor that. We don't have a way to monitor what's happening at the myocardium. These are futuristic things.
Yeah, go ahead.
Bill.
Yeah, so I'm the co-PI for DTU, so a little more context. You're absolutely right. The mortality, the in-hospital mortality for anterior MI is very low. But you have taken care of a 40-year-old guy that comes in with an anterior MI. You open up the artery, he looks fine, and then you get an echo pre-discharge, and the entire anterior wall is akinetic, right? So that's going to set a trajectory for this patient for the rest of his life, and it's ultimately end up with adverse LV remodeling and low ejection fraction and then he's going to be a candidate for an artificial heart in 15 years. So I think that's really what we're trying to do, try to limit, and it's not an all comers, it's just anterior MI, large anterior MIs, to see if we can decrease LV dysfunction. Now, you and I were in PAMI-2 together in 1995. That was the first attempt with balloon pump to decrease infarct size. So there's been a lot of attempts to do this. So I'm not going to promise you that this is going to be a successful trial, but in the pilot, the operators were able to sit with an occluded artery for half an hour, and they weren't compelled to go forward because the patients actually did very well. Their blood pressure came down. ST segments actually dropped while the impeller was in. So I think there's some hope for optimism, but I can't take this to the bank yet. We have to prove it. And it's a very well-organized trial, and we hope to recruit well. The door to balloon time has been a real confounder because people are just really worried about, you know, what the public perceives in terms of opening up the artery. So we'll see, I think, but it is started. We're randomizing. We've got about 15 patients that have already been randomized, and we hope within about 2 years we'll have the answer.
You know, and the final point, I mean, I think, just changing for a second, the bit about looking at a multi-scale level, we need to identify the variables. Sort of, I know you're going to hear this afternoon about inflammatory markers. You know, if you think about medicine, little variables come out, we kind of adopt them in our practice. We don't instantly shift to this new paradigm of here's a mosaic of what I'm going to use today, and then in 2 years I'm going to get a whole different panel of biomarkers to evaluate. I really liked what Now said this morning, that they're different purposes. I think we need to continue to dissect the molecular mechanisms of what's going on in shock and then identify what could be valuable. But then we need to figure out a way, because we're sort of being led in medicine. We can't just pull this test and pull that test and different outcomes and people are looking and quality. We have to figure out a way how to create these panels that may be valuable long-term, and they have to be quick. The problem with this, as we know, is you can't, you know, send it off to some lab in St. Louis in 2 weeks and get it back. You need instant data at the bedside, and it's tricky to put it all together.
Thank you. We'll have to get it going and discuss.
Thank you
this
very
wonderful
much.
discussion. Thank you very much.